Amendment.
It's May this year.
May, wait, May is when we do the pay or when we do the officers?
The voting in May.
Oh, okay.
This still has some corrections. This may not be that final copy, but I didn't make any
You didn't
changes.
change that?
We didn't change that section.
So in one of these areas, we'll just make sure that's clear, so the voting is in May,
Okay.
and then the slate in April.
Does it say when the elections start?
Sure, on a yearly basis and voting in May. So I would assume that we will start after the May.
So June or July. Okay,
Yeah, thank you.
okay, I guess we're gonna call the meeting to order. And Christina, you have everything you need from a who's here
Yes.
perspective? Okay, do we have a quorum?
Yes.
So,
Perfect. So welcome everyone to our meeting this evening. We're going to start the meeting with public comment.
Is there anyone online?
Jen would like to speak.
Hi, good evening, everyone. Jen Danzer with Namiolo County. I just wanted to let everyone know that our annual Celebrate Hope and Resilience event will be held on May 15th. It's going to be a luncheon from 11 to 1 at El Macero Country Club. Tickets for that event will go on sale Monday, February 10th. And this year's honoree for the Pat Williams Mental Health Luminary Award will be Carlene Jakowski. We're very excited to be able to honor Carlene for just her long-lasting contribution to mental health in Yolo County, and we would love to see all of you at the event. So thank you, and appreciate being here this evening.
Thank you, Jen. Thanks. Any other public comment? Okay. So our next item on the agenda is the approval of the agenda, actually. We have a motion.
so moved.
Seconded.
All in favor?
Aye.
Any opposed? Any abstentions? All right, the agenda is approved. The next item on the agenda is the approval of the minutes from January 8th. Is there any discussion around the minutes or items? Do we need a few minutes? I'm going to take silence to go forward. Do we have a motion?
So moved.
Second? All in favor?
Aye.
I'm
Any
sorry, I
opposed?
didn't catch the second.
Who was the second?
I think we both did at the same time.
Oh,
no,
Vicky
Melanie.
did.
Okay.
Yeah. Thank you.
All in favor?
Aye.
Any abstentions? Any opposed? Sorry. All right, we have an approval of the minutes from January 8th. The next item. I'll carry you through the. Do we have any member announcements?
I have another one I wanted to announce. For anybody who is interested, they're going to be having Cal Voices. We'll be having a Medi-Cal Peer Support Specialist Certification Training. So all you have to do is go to their website, and the next cohort will be April 2025. It's like a 2-week course, so it's a really good opportunity for some people to be able to get that certification.
Yeah. You might want to explain for the record what that's about, because it's really important. We worked hard to get that.
Do you want to explain it for me?
Okay.
I mean, yeah.
Peer support workers have been engaged in helping people with mental illness for a long, long time. About 4 years ago, we got a bill through the legislature that allowed peer support workers to be able to be reimbursed, for Medi-Cal reimbursement. And that was a big deal because we have to have them certified in order for them to be eligible to bill Medi-Cal, and it takes a big load off of the departments, because their costs are offset, and it encourages us to be able to use more peer support rather than less. Did I explain that reasonably well? Chris, you're looking really puzzled.
I just wasn't taking you certified, is gonna be my question. I
Oh.
understand how the peer support workers work, we have them,
Right.
some specialty courts and other programs, and they're vital. I just, what does the certification entail?
So basically, you go for 2 weeks. It's pretty intense. You do have to commit, 2 full weeks, so many hours a day, and you have to take the test each day. I've been through it myself.
Mhm.
And then from there, you have to go to the state and then become certified. And then once you're certified with the state, then you're able to actually be paid, like you said, through,
Medi-Cal.
Medi-Cal
We could bill
reimbursement.
through Medi-Cal.
Yeah.
We can
Yes.
they're able to bill Medi-Cal, yeah.
Yes.
Yeah.
So
I didn't mean you go directly to Medi-Cal.
so it's a way for you to have more peer support workers if they're certified, so you.
It's a,
It's
you
a way for
general
us,
funds.
it's a way for us to generate revenue.
Yeah,
We use
okay.
peer support workers. So we have peer support workers who are not certified, and they're able to provide all kinds of supports for our clients, but they can't bill Medi-Cal for any of the services. So my understanding of the challenges of this are that one of the requirements is that they have to have a high school diploma. Many of our peer support workers don't have a high school diploma. Also, that there are some pretty
rigid.
rigid and rigorous standards around the certification process that can be challenging for some of our peers. And what I understand about it is that they're not very accommodating, right? Which is odd. Yeah, it's like it's ironic, right? You know what I mean? So we do have a few peers who have been through the process. I think we're sending 5 peers to a training here that's coming up in the near future, right? And so of course it's something that we are highly motivated to do, but again, we have some peers that are already working that are highly effective with what they do, and
Yeah.
they're not eligible to even participate in the training, so.
But the training standards, the thing that Medi-Cal was concerned about was that they would get disallowances from HHS for people who weren't certified if they tried to bill them. So they have to have, they believe they have to have a certifiable program that will allow them to be able to do this. It's not it sounds like they're just being hard-nosed or whatever, but I think they're really trying to protect Medi-Cal, the integrity of Medi-Cal funding, so that they don't get a lot of exceptions.
So can I comment on this? I know a little bit about it because my son's a peer advocate. Unfortunately, it's well-intentioned, but there's really no incentive for the peer advocates to get certified. Right now, they're being paid not out of the general fund by Mental Health Services Act dollars, or I should say Behavioral Health Services Act dollars. It's rigorous, and for a lot of the population, it's challenging for them to do this. And I actually had a phone call with Carlene about some other stuff today, and the new job she's at, that's one of the things they do, is they work
Yeah.
in the area of peer advocates. And one of the things I talked to her about, which I'm glad to put on the radar of this board, and also Nolan and Tony, is, this isn't a reflection so much on Tony and HHSA.
I'm glad to hear that.
Yeah, it's more statewide. So let's put our money where our mouth is, and if you really believe that this is an important group, well, then let's have them have real jobs with benefits. Because right now,
Yeah.
they're all working that half-time,
Yeah.
so they get no benefits.
Yeah.
And these are adults no retirement, no time off, no vacation or anything like that. I know it's a challenging time to make changes like that right now, and it seems like it never gets a lot better. It just gets worse or it gets okay. But, so that's one of the things. And so there's some discussions, well, maybe the certified peer support advocates could be the ones who could get, the full-time positions. But as I said, there are a lot that really can't or don't feel they can get the certification. Because as Melanie said, even, it's challenging. So if it's challenging for you, imagine how it is for a lot of the population that might be smart enough to do it, but it's other issues like anxiety that might raise real challenges. So I would like to see this board, that be on the radar and advocate for that, and that be on the radar. And I think it is. I think you guys have been kind of thinking about it. Carlene said that's one of the things she wanted to be able to do. It's tough with all the hiring freezes and this and that, but I'm just hoping that we get to a place where if we truly believe what we're saying about the value of these individuals, and I think there is, that we put our money where our mouth is and we, pay them what they should get paid, a living wage, and that we also, let them work above the amount of hours where they can get some benefits.
So another complicating factor, though, is that many of our peers receive certain kinds of public benefits
Yes,
that are
and-
difficult to obtain in the first place,
Right.
right? And many of them have a fear of losing those benefits, right? And so
And that's especially true for the
rising to
SSI.
a certain income
Yeah.
threshold or receiving benefits or things like that, it's almost counterintuitive because some of our clients are afraid, like, if I lose my benefits and then I ever need them again.
Yeah.
It's such a process to get them, right? And so.
And many of them had to get lawyers to get them
We
in
are
the
all,
first
we are
place.
also balancing that out. Because I think that there have been situations, and that's what we'd love to offer people full-time employment, right? And it's just not right, so, I mean, that's definitely on our radar. We're aware of.
Yeah.
We're aware of the complications with it, but we believe in the fair model, right?
But the ones that have benefits now through a program like SSI or whatever, already have their medical taken care of because they're automatically eligible for either Medicare or Medicaid. So I think it would be a good idea for us to check with some of the other states, because that's how the training program itself came. I'm trying to think what state.
Counties or other counties?
No, where the training came from,
Oh.
how the training got approved and whatever, was because there were some states that were already doing it.
Is there a way to do a different pay rate for someone who's certified? It would probably be a win for the county if you bill Medi-Cal for it.
Can I just
Yeah,
interject
that's
here?
positive.
What is it that we're hoping to see that we're not seeing now?
I just wanted to share that that's out there. If anybody-
No,
I was
just
trying
wanna
to
make
come
sure
with
I'm
something
understanding
positive tonight. I've been
the
negative all the time. I thought, let me bring some good options.
Just in general, right, Yeah.
I want to see them being paid a living wage,
Mhm.
which they're not being paid right now.
Mhm.
I want to see the opportunity for them to not be part-timers and for them to get benefits, whether if they can't work 40 hours a week, it's above the threshold, so they are get some benefits. Notice how I didn't mention medical, because I
Yes.
understand that, but there's retirement and there's all sorts of other
Vacation.
benefits,
Yeah.
vacation. And they are doing this in a lot of other counties across the state. I know that because, I serve on the advisory committee for our association for local behavioral health boards.
Mhm.
So there are a number of counties, I don't want to say a lot, because that would be, I don't know that for sure, but there are a number of
Mhm.
counties that are doing more in the space of peer support advocates than YOLO is doing. YOLO is one of many that are doing the same, so I don't mean to put you in a bad light, but some of them are doing better than others are doing. So that's kind of what I think we should be doing.
Well, there's a couple of like job openings that they sent. I just got the email today. In Auburn, they've got family advocate. Sacramento, they've got peer community health worker. Jackson, they've got a peer support specialist. They're averaging about 22 to 24 an hour with benefits. So, I mean, that's a good starting wage. I don't know what our county, if it's something that we have in place, but I mean, they don't even have to work in our county. They could go to another county if they could. Sacramento's just a couple of miles away, you know, depending on where they live.
Mhm.
But it is very strenuous. I did take it. It was pretty stressful. But if you get the certification, it's not gonna be easy because it's like any other certification with the state. They can't lower the requirement
Right.
Mhm.
when it's a statewide thing. So, but even if we had one or two people that were interested, there you go.
Yeah, I just wanted to kind of chime in as someone who's been through the training and recently gotten certified. I think took a test in like December.
Did you pass it?
Yeah.
Yeah.
But essentially, yeah, echoing what you're saying about like a lot of transport workers aren't interested or maybe aren't being paid a living wage, so then that's a barrier. And then the other thing is the timing of the trainings. Like, so for Cal Voices, I think they have you do a 2-week block on your life, and then for some people, that's not super accessible.
Right.
So kind of offering like different timings for the trainings, I think would help like more populations be able to do it. And then also like, I'm sure you've also seen when you go on the certification website, there's literally like 8 steps and you have to check off each one and it's not intuitive. So then that's also like, even to people that don't have mental health conditions, it's not super accessible either. So I kind of want to reiterate like the accessibility concerns you both had. But what I do also want to say is the content of the training is great. So like they go into like a deep dive on like how to do public advocacy about the MHSA, like how to do like a RAP plan with another consumer, so wellness recovery action plan. Like it's really like wonderful training. And if anyone has the time or is interested, I'd really recommend like signing up for it and kind of seeing what it's about, even if you don't plan to get certified.
Two quick additions. So the Yolo County wage for mental health care support workers starts out at $19.39 an hour and caps out at $23.57. There's 5 salary steps in between there. So it's above some of the ones you mentioned, but it's not fantastic. I think realistically where we're probably going to move is enforcement of folks being Medi-Cal certified. The county just is not in a position and will not be in a position in the next couple of years to continue to spend MHSA, IGT, realign. We're gonna have to get reimbursement. So we sort of discussed this firmer line. There is a lot of anxiety and a lot of folks don't want to go through the certification for a variety of reasons. And so it would be problematic, but I do think at least discussing with this board, because when we have to draw that line in the sand, you'll hear from folks. It's not that we want to be cold and callous and push people into a program that they don't necessarily want to do. And there is lots of hesitation, but we have to get reimbursed for our expenditures. So what we've been talking about over the last year or two is really moving to a place where we require Medi-Cal certification, because we just can't continue to spend in certain areas. We're not going to have the funding for it. So I would suspect over the next year or two, you'll see some hard lines where folks actually have to have these certs, and that may impact some people negatively, which I'm not excited about, but it sort of is what it is.
Is there a way to do a like pre-course internally to try and get them prepared to be successful?
Yeah,
There's
I
a lot
think-
of anxiety.
Yeah, I think we'd want to, I love that idea. We could do a 6-month runway, get folks ready, do a study session, ask for volunteers from, that's great, absolutely. Yeah, we want to set people up to succeed, but we also have to have our revenue sources. Meg, sorry.
I was gonna say the same thing, it just seems like there's an opportunity to get creative on how we
Totally,
support people
yeah.
to get this done.
I think that's a great idea.
Because I agree, we need, I mean, if we don't wanna leave money on the table, right? So, yeah.
Yeah, I think that's a great idea. So we can kind of noodle that around a little bit and maybe even come back for some ideas and volunteers from this group to kind of get that process started. But realistically, we're going to have to go after every dollar that we can get over the next couple of years. It's going to be rough. So.
Are we at chair? Okay. Yeah, sorry about that. I was caught in traffic from Sacramento. I apologize. So some sad news for those of you that haven't heard. Sue Gaines is her son, Jess, died on January 6th. Her son was a graduate of the mental health court many years ago. I remember playing softball with him in one of our get-togethers. I just found out yesterday, I knew that's why she hasn't been here, that he was ill. And she had said she was going to resign from the board. And I said, how's Jess doing? She said he died on January 6th. So I have a card for her. And if you guys want to sign it, there's also, I don't know if we can fit everyone on here, but I have a sheet of paper. If it gets, don't feel like you can't write a lot, because I have a sheet of paper we can write on, include, and I'll just go clockwise, I guess, if you want to write something for her.
Hey, Jonathan,
Yes.
would it be appropriate, would it be appropriate for anybody who wants to make a donation to the moment?
Yeah.
Definitely. If you're in anybody's group, I don't want to put pressure on anybody, but just.
We should send something out how we could do it, and we can each do it.
Yeah, people want to.
If we want, yeah.
Okay, so sorry for the sad news. I'm trying to think of some happy news I could share.
Our new board member.
Yeah.
Welcome.
Oh, yeah, I don't feel like you're a new board member. Yeah, so we have a new board member. Do you want to just really quickly, I know some of you, just very quickly introduce yourself, because I know you did when you presented to us, so a lot of people were here, but for those that weren't, if you want to just quickly introduce yourself, that would be great. Welcome, thank you.
Hi everyone, I'm Nithya. It's nice to be here again. It's nice to re-meet some of you. I am a fourth year student at the University of California, Davis. And I'm super excited to be here. I don't know what else to say.
Welcome.
Thank you.
You're planning on sticking around after you graduate?
Yes. So I'll be living in this area for at least a year after I graduate, so I'll be around.
County's always hiring.
All right. Correspondence? No? Okay. Let's go to Tony, your first mental health director's report. Do we want to pull items? Anyone want to tell me what items they want to pull?
Should you just run through it? This is
So when you say, so there's a suggestion we run through, what do you mean by that? Like having to do every report of it?
Well, people do want to read it, we should get it until we got here, so.
Yeah, I do. I apologize. I was a little behind schedule.
I'm not complaining, I'm
No,
just saying
yeah, I
practically.
know that we normally check these
Oh,
out. Yeah, they're there, so they're pretty.
Do you want to just,
Well, I mean, I'll give
just
my
give a
best
couple
shot.
sentences on each
I
section?
will give it my best shot, yes.
Okay.
So, item A, the leadership transition at Health and Human Services, we talked about this last time. When Carlin was here, that was her last local behavioral health board meeting, and I am in the role of the interim mental health director. Marissa Green, who's here today, is in the role of the interim public guardian. And we're in the process for actively recruiting to backfill Carlin's position. So if you look down here at the bottom of page 1, there's some web links, or you can use your phone if anyone's interested in applying. We are running the recruitment until March 2nd. All right, item B, current request for proposal. So we're working on 2 RFPs right now that relate to the Crisis Now project. One is for the Operation Behavioral Health Crisis Receiving Center, and the other one is for a mobile crisis response. We decided to bifurcate them just in the event that we felt like if we put them both together and required proposers to do both scopes, that maybe that would be too much, right? Or if we put them out there and just said pick one or the other, that maybe people would only pick one and not the other, right? So our plan is to release them separately. Right now, we're trying to firm up the funding for the Behavioral Health Crisis Receiving Center. There have been some funding that has been committed by some partners in the past that we're not 100% sure if it's there. So we're looking at a couple of different options. And once we get that sorted out, our plan is to release the draft RFP to the cities to review, and then we'll 2 cities and 1 hospitals. Yeah, thank you. Any questions about that? All right. The Mental Health Services Act and Community Engagement and Annual Update Process, we're about to start that. So the kickoff event is on Wednesday, February 19th, 4 o'clock. You should have received an email earlier about this already. So at the time when I was writing this morning at 5 a.m., an email hadn't gone out yet, but now it has. So I'm sure if there's any questions about the engagement and annual update process, I'm happy to answer them, but I'm assuming that many of you are already familiar with that. Okay. CARE implementation, this is a lot of the same content that Carlina provided last time, and we're just providing a quick update here that we've received 3 petition orders from the court and 2 internal referrals. We're actively engaged with all the referrals, and the first court hearing was last Friday. CARE Act teams collaborating with the Access team and with the Police Department Homeless Outreach and Services team to engage the individuals who've been referred, and we're learning that the required data components and completed training. The CARE teams has learned about the required data components and completed training for the data demonstration. And there's some information on the pages aren't numbered, but it's the 3rd page. It's basically just, again, providing information that was part of the CARE Act and how to initiate this process for anyone that's interested. My intent here was just to make sure that this shows up somewhere on our website, right? In the meeting notes.
It's a nice resource.
Yeah, well, Carlene did all the work. I formatted it slightly differently, but other than that,
It's nice though.
all right,
Out
so.
of memory last week, is the state providing any funding for this, or any long-term funding?
For the CARE Act,
Startup funds, but no.
It's the STAR funds for the court to design the program.
There were department funds available as well, and there were earlier cohorts in different counties that got much more than the counties that were there.
Okay, so it's another funding requirement for the county.
Yeah.
I just have a question or a comment, I guess. So I tried to file, I actually had an appointment, went in to file. But my loved one did not meet the 60 days of intensive treatment. So I needed to have that CARE 101 completed. But because that form is a confidential HIPAA type related form, I was not able to attach that to my CARE 100. So therefore I'm not able to file it. So how do we do that?
Julie behind you is gonna field this.
Yeah, I
She's our care
And
court
I know
expert.
the last time I was here, we were
Yeah.
talking about that, and I was like, oh yeah, just go down, you can fill out.
And you were right
the
to a
form.
certain degree, but.
Yeah, but there was some discussion that happened kind of after that with our team and then also the self-help center. So we have a consultant for CARE Act, and they're gonna meet with our court partners and all of us kind of together. We have like a pre-meeting, and now we're gonna meet with everybody just to talk through the 101, because it's a super nuanced form. And technically, you don't really need it depending on who's filing the petition. But there was some sort of, because it's so nuanced, there's some misinterpretation of it. So we're working through that right now. But what I said in the meantime was, if there's any questions, you know of anybody who has questions about the form, just contact our office and we'll do it for you.
Maybe I can get your card after this?
Yeah, sure.
So like I have a window right now, opportunity
Right.
where my loved one is safe or captured or, as far as I know, as of like last week, this is a time to file, I don't know, I know it's a voluntary type program, but I think it would be good timing to at least give it a shot.
I'll just say this as a more blanket vague statement. If our office becomes aware of somebody who is needing a petition, we're filing those. We're filing those petitions as we become aware.
That's great. That is nice.
Thank you. Thank you.
yeah, no problem.
And I want to thank Julie really quick. I mean, it's been a really big, challenging, scary, confusing project to figure out, and Julie has pretty much single-handedly figured that out. So we have superheroes that know our capes in Yolo County. Julie certainly is one of those. So it's a big thank you.
Yes, thank you. Thank
Wearing
you
my
now,
work
thank you in the,
jacket.
thank you in the future. Because you're gonna have probably a lot more.
Cold Kate.
And that's how we learn, right? Is it comes up when we go to file and then we run into it, and then we learn, we figure it out.
We're
So,
learning through mistakes and bumps, and Julie's been there and stepped away, so.
Yep.
That's for Jess from the health board.
thank
Okay,
you.
and there's 6 referrals now.
Six,
Caught up to
six,
precedent.
Okay, all right, we're up to 6.
Wow.
6 referrals.
Did you want?
Any other discussion around the CARE Act implementation? Okay. We are in the process of recruiting for a crisis manager position. Last time when Colleen was here, we had explained that we were about to start that process. We were requesting someone from the local behavioral health board to participate in the interviews, and thank you, Melanie, for doing that. So we've had the first round of interviews, and we're moving forward with the next round of interviews. We had a little bit of a delay just because of hiring freeze, a countywide hiring freeze, but this position has been cleared for us to move forward on. And my intent is to have the final interviews next week. So the intent here is to try to get try to get someone hired for that position to oversee all of the crisis components. So that would include mobile crisis response, Crisis Now, our access and crisis line. So all things crisis, this manager would be overseeing. Okay. With Children's System of Care, these are updates that have been presented here before. We're just making sure that it continues to be on everyone's radar, some of the work that we're doing on the children's side. So we had applied for and were awarded a CYBHI Round 5 grant to build out a school-based mobile crisis response unit. And we're still in the process of working to get the position approved to hire, right? So it's going to be a limited term position because the grant funding is time limited. It's 18 months. And the goal here is to have a single individual who is familiar with all of the different school districts to be able to respond to school sites if there is a behavioral health crisis, so that we don't have law enforcement showing up or some other system that might not be as appropriate. And we're modeling this after an existing model that is in Solano County right now. That model is operated by the Office of Education, but our intent is to have that be an internal system and then to kind of learn about how it goes and figure out funding for it down the road if it's possible. We're also working with the probation department to provide services at the juvenile detention facility using PathJI funds. And those funds are currently fully funding an HHSA clinician who's co-located at JDF, at the juvenile detention facility. That person's providing an array of clinical services, including a life skills group for youth in custody. And finally, we've contracted with Carroll Lake to provide outpatient and intensive outpatient substance use treatment services for adolescents in Yolo County. The services are relatively new. It's an accomplishment for Yolo County to have a full array of substance abuse treatment services available for youth. We also have the ability, if we have a youth who needs residential substance use treatment, we have an ability to contract with the only game in town down in Los Angeles. It's Tarzana. They refuse to contract with us, but we have a memorandum that on a case-by-case basis, if it's necessary, we can send youth down there.
Tony, can I ask if you can speak up a little bit? I may be
Sure, sorry.
I may be losing my hearing, but I'm having a hard time.
Kind of turn your, there you go.
I will try to talk much louder.
Thank you.
Good question. That's great news about the grant. Curious, do you think you'll be able to find a limited term? Is that something that you anticipate will be a hurdle or?
We believe that if we get the position approved in the current environment that we're in, we believe that we can fill the position.
Okay.
How long is the period again? Did you
It's
say?
18 months. And so we're kind of butting up against it's already in process, so the quicker we can move, the better. But it'll be a limited term clinician, and then we have an existing behavioral health case manager position that would support this as well, right? So it'd be a clinician and a behavioral health case manager that are specifically tasked with providing mobile response to school sites for crisis.
So for the limited term, is it a benefited limited?
It would be a full-time position.
Just time limited.
It'd just be time limited. So when we hire for limited term, you're not guaranteed to work past a certain date.
Right.
It's 2 years generally.
And is
3
it,
years is the max. I'm finding out the hard way. Did you have a question?
Yes, so this kind of encompasses like several of the points, so crisis now, the receiving center, school-based level crisis, and the crisis manager, but I guess in kind of building out all these systems, how do you plan on incorporating the consumer feedback?
That's an excellent question.
Into like, first like building it, and then also kind of once you've implemented it, like how are you planning on hearing consumer feedback? Because in, like last year in the community engagement meetings, I saw like predominantly it's kind of family members giving feedback and not a lot of consumers. And so, but to building an effective system that's compassionate, like you kind of need to get that.
Yeah, I mean, I'm definitely open to some suggestions about how to do that. I mean, in terms of the community engagement meetings, I was there last year and it was not very well attended, right? So I think we can also do a better job of trying to get the word out there that it's important to get this feedback from the community. I think that when you start figuring out how to get feedback from clients, right? It can be a little bit challenging, right? Because some people don't. You can give people surveys, or you can provide them opportunities to provide feedback in a very formal way like that. And some people don't want to do it, right? Some people may feel pressured, or if you provide like a forum, some people may not want to present and identify themselves. I have a very similar dilemma on the child welfare side, right? We love to get child welfare feedback. We have town hall, sessions for people to kind of give us feedback. But we fear that if we had them in person, that people wouldn't want to come, right? And so I think that because there's some stigma around some of the services, we may not be able to get feedback in that kind of manner, right? So it's a great question, and I think that it is valuable for us to consider that when we're building the systems out and modifying them to meet need. But I think I would be open to receiving feedback from individuals who may have a better understanding about how those clients would prefer to be approached, right, to provide that feedback, rather than just kind of coming up with a plan on my own. So I would love to talk through that sometime and develop a strategy for that.
Yeah, because what I kind of want to prevent is sometimes there's a little bit of a gap in terms of what the clinician thinks that the community needs or the person needs, and then what the person actually wants, or kind of like, because you're dealing with a population that often isn't heard and often isn't believed, then like the provider can kind of be doing what they want, and there's not, like in that interaction, they don't think there's any kind of repercussions if they, like, worst case scenario, you want to believe that people will kind of be professional and do a good job, but then in reality, that doesn't always happen, and then the people that are being served don't have an avenue to kind of like, I guess like bring up their concerns about that, so that's kind of what I want to prevent when moving forward into this new system.
What about private Zoom
And
chats? Would that provide like a safe space, do you think?
You mean if we're doing community feedback?
Right, so you have
Yeah,
like the main hub and then you branch off into private rooms if they want that one-on-one.
I can just speak to what we did about 2 years ago now, right? With our child welfare town hall, and we did do it virtually. So we had a Zoom room, and so that people could choose to remain anonymous if they wanted to, and they were able to provide feedback in that manner, right? So I think more to what you're speaking to. So the first thing I'll say is that if someone receives one of our services and they have a complaint, there is a process to do that. We have a confidential line that people can call and make complaints to. We have a whistleblower line. Our compliance officer, Catherine Barrett, is here tonight. She's the one who would receive those kind of things and then look into what's happening, right? So if someone does have a complaint to make about the services that they've received, regardless of their crisis services or not, there is a process in place for that person to make a report that would get looked into. And it wouldn't necessarily change an entire system per se. It could, I guess it would depend on what the complaint was about, right? But there is a mechanism in place to provide a complaint. In terms of what you're talking about, it's like direct feedback that will inform how the system should operate. And again, I think that, to what you're saying, we could do it like that. We could provide a forum where individuals could come and provide some sort of anonymous feedback or something like that. But that becomes a challenge too, right? Because if the feedback's anonymous, you don't know if you're getting accurate, you don't know who's providing the feedback, right? So again, I would be open to discussion. And I see Ms. Barrett here would like to chime in.
And just kind of quick avenues off the top of my head, again, like I haven't exactly worked in this, so that I don't exactly like know set avenues of like you're already talking about giving feedback, like what you talked about with the child welfare system, but just off the top of my head, like existing peer groups. So NAMI has existing peer groups that meet and have encountered these systems and encountered these systems a lot, and they're probably a population that could be talked to about this. And the other thing is, I know for a fact that the current co-responders do follow up on individuals. So phone calls sometimes meet with them, so during these phone calls or the follow-up, they can also incorporate like, hey, there's like this anonymous feedback, would you like to fill it out? So for sure it's someone that has received mobile crisis services. Or I think at one point, I'm not sure if this program is still going or not, but at one point the Yolo County like crisis line, so like the not the resource line, but then like suicide prevention Yolo County, I know that they were following up on people that had been discharged from the hospital for psych reasons. And I'm not sure if that program is still going, but that's also an avenue of getting feedback, like from all these services. So there's ways people have been contacted post-service, but then,
There are some routine quality assurance processes that we already have in place for that anyways, right? So that happens periodically over time, and there are different times when there's like specific, not necessarily an audit, but there's specific times when we are reaching out en masse to all of our clients to receive feedback. Again, I think to your point, right, how are we integrating consumer feedback into the process to inform how the services should operate? I'm open to that, right? But I can't tell you exactly what that's going to look like right now. Okay. I see Ms. Barrett.
So one
Desperately
suggestion
wants to
would be,
speak.
I think it's a great idea. We have a wellness center, and it's particularly here in Woodland, it's well attended. So that would be Tony, and maybe if you would like to sign a confidentiality agreement, you're welcome to come, maybe accompany Tony and talk about what that would be to get feedback for some of these resources. Because we have plenty of folks who are there who have used our system, and I'm sure would be happy to chat about it. And they're in their environment, their comfortable environment.
Another option is, I know in the past, we've gone to our participants in our collaborative courts. And I know like Terry helped coordinate that, so that's another option for you.
I would love to talk about that in item I, we're gonna talk a little bit about that.
I think big picture, we're building a crisis system of care really here in Yolo County. It's still a, newborn fledgling kind of system. It's gonna take us a year or two to really get it off the ground. I guess my ask to you would be to keep holding us accountable to that. I mean, at this point, all focus is on like, can we just launch these systems, right? But I think that's a really important question, and frankly, like, keep us honest, right? And keep asking. I mean, it's not gonna happen tomorrow. Help us get the doors to the receiving center open first, and then we'll kind of talk about that. But I think that is a really important next phase, and that's a really great place for this board to continue to hold county staff accountable. I think at least with the crisis system of care, we're probably a couple of years out from really having some sort of robust collection methodology. The only other thing I'll add is we are trying to really beef up our administrative support in this area. We're hiring a crisis manager, right? Right now, our access manager and crisis manager has this huge span of control, right? We're trying to add another assistant or deputy branch director to work under the mental health director and adults to really help with all these big projects and build out these systems and feedback loops. And we're starting to try and kind of build that capacity. So it's tough, but I don't think we'll be there soon, but I think we'll be there in the next year or two or three. But I would love, again, put a pin on that and keep holding us to it, because that needs to happen. Other systems of care in the county, we certainly have some existing feedback loops, but this is an area where after launch, we certainly need to pay some time and attention to and really refine the process.
Yeah, definitely, because in the current system, like, it's improved, like, I've encountered this myself both personally and professionally, right? And I've definitely seen, like, in different places over time, sometimes a county will have like a surface level kind of like presentation of how their crisis system works, but then functionally how it works to people in it.
Yeah, oh yeah.
It's two different things.
Yeah,
so
100%.
as in like, they're like, oh, we're super professional to mental health patients that we encounter on calls. And then towards the mental health patient, like they're gonna
100%.
Yeah, and then there's kind of no way to kind of say anything about that kind of treatment, because again, it's a demographic that isn't believed.
Sure.
is extremely vulnerable, you know? And so I just kind of want to, like, as we're transitioning from the kind of like police, ER,
Yeah.
hospital kind of emergency mental health to a mobile crisis receiving center kind of mental health, I want to make sure like, hey, are we incorporating feedback? Are we having a compassionate approach? Because I think of everything else, compassionate approach is the biggest thing.
Yeah.
Yeah.
I agree. I would suspect that as we move forward, budget permitting, that's always my first caveat, right? Is we will have some sort of ombuds person that would really hold that role. And we've seen that be very successful in other systems of care. So as we get to that, I think that's so important because like you said, many of us don't go through this system, right? And like you said, folks have all sorts of different barriers, whether that be issues for them to even report the issue or not being believed or those other things. So I think this is certainly the next iteration of where we're heading. The other piece of that is a big chunk of our crisis system is contracted out, right? So you've got contractors doing work, you expect them to do good things. Our contracts now are pretty firm. We have performance measures now, Jonathan, in all of our contracts, right? So we'll have performance measures on data, quality, and other bits and pieces as well, but who is also making sure those quality measures are being hit? So I think you bring up a really good point. I think Tony and I were actually a little stunned by the question because we hadn't quite thought of that yet. But again, as we build this system, like this is where we need to go next. So keep holding us accountable on this one.
That's why it's like consumer perspective of the board.
Totally.
Like,
That's exactly it, yeah.
I'm doing my job. Yeah, thank you.
Sorry, and then I won't beat the subject anymore, but I think there's also a piece of it is the outpatient mental health where it's not crisis, but
Sure.
you know, you're staffed up with physicians now, which is awesome.
Yep.
And so really what is the medical director overseeing that is how is the consumer also, you know?
That's a great question.
So
Yeah.
I mean, kind of, so
Yeah.
I think I see it as a continuum.
Yeah, I agree.
Kimberly brings up a great
Yeah.
point, but I think it's also the continuum. So as you build out your metrics,
Yeah.
really think about where's the consumer's voice in each.
I love that.
Bucket.
And Dr. Dutter really has his feet
Yeah.
under him now, so I think we could certainly engage in those conversations. So that's a great, I'll make a note. Maybe we'll bring something back to this board.
Yeah, because
in
I
that
think
respect.
from this point, I mean, whether it's physicians or not, people, there is a power dynamic.
Sure, 100%.
And so, yeah, it'd be great.
Chief? I appreciate the question, though.
Yeah, great question.
Okay, speaking of Dr. Dutta, there's a quick update here where he's commenting that we have a stable team of psychiatrists, nurse practitioners, RNs, and MAs serving our county clinics and wellness centers. Current priorities: coordinate and streamline the implementation of CareCorp with the forensics team. There are some systemic challenges, including concerns regarding funding related to next year's fiscal budget, the lack of inpatient beds, and limited transportation compliance in rural areas due to staff shortages. Our focus in 2025 is to retain staff and to maintain existing services. And I wanted to acknowledge and recognize the medical staff, crisis staff, and Carlene and Nolan for their support. But not me.
I didn't add to the report, but if the chair doesn't mind, I'll add a little just general county flavor, if that's amenable. So the county right now is in a full hiring freeze. And so all hiring in the county is frozen through March. We have been given the ability to push exceptions through for what we're calling public safety positions. And so it's been a lot of work behind the scenes, a lot of focus and kind of tracking these down and back and forth with HR and the CAO's office and the budget office. So we are moving forward some clinicians, but it's really messy right now. So I just want you guys to know we're really struggling with filling positions, getting vacancies covered. As Tony mentioned, we're starting to lose limited term folks. We're losing extra help folks. We were just talking about a person who terms out next week and there's just not a better option to keep them. So position wise, it's been really rough in the county. We have 102 vacancies in the department as of today. I was just allowed to fill 40, so we have another 60 that are kind of hanging out there. So the good news is on the mental health front, most positions are moving forward. But the bad news is we still have accountants and trainers and people that do facilities and all these other things that are held vacant. So it really gums up the whole county system. So again, that's through March, and there's no guarantee that's lifted. That might continue. The county has a structural deficit issue with their general fund, which means we're spending more than the general fund's taking in. And so we've gone through a variety of budget exercises to see what a reduction would look like next year across the county. And so we're moving through the budget process now. I see Supervisor Ferrick's on the call there. The board is kind of actively diving into our budget, but it's not looking great. So just wanted to kind of put that out there. Realignment for mental health right now, we are projecting close to $1 million deficit next year. We're going to spend our fund balance down, it's gone. MHSA, we've got about a $6 million fund balance right now, but we do project to carve into that by about $3 million. So we're kind of hitting like the bottoms of the barrels in all of these areas where we fund mental health services, and so it's not looking great. So just kind of keeping all of the things we talk about in context. Funding is going to be very challenging as we enter this next BHSA plan. You know, we are going to be even more constrained by the 3 categories and kind of where we've been spending funds. So the fiscal situation continues to deteriorate. It's not getting a whole lot better. The good news, state's somewhat stable. So realignment is at least stable. We have a deficit, but it's stable across the state. So the state budget is really kind of the only, and I don't want to say good news, but sort of stable news. And then we just don't know what the federal government's going to do. So we had a really rough week last week. So back and forth with maybe medical funding or Medi-Cal funding. So funding wise, there's just it's a really shaky and kind of rocky horizon for us to kind of navigate through. And the things that we do know today is we know that we are financially really struggling in all of the areas that fund our core mental health. So just kind of putting that out there. I think you guys will probably stop inviting me to these meetings because I always share downer messages. It is what it is, and we want to be real about it. And I think that we're going to have to pare back and limit and probably cut services, which is never fun, but there's just no way to continue at the rate that we're going without blowing multi-million-dollar holes in our fund balances. And so it's going to be a tough couple of years.
So you mentioned something about public safety. My understanding is the county was going to allow you to hire individuals that weren't funded by the general fund. So much as we all know, a huge portion of your budget is not the general fund, which is a bad thing.
Right.
Over in Placer, they're flush with the
Yeah.
general fund. It's not that way in Yolo, which is sad. But is it true that you are not only able to hire the public safety folks, but the folks that aren't funded by the general fund? Because that wouldn't cost the county anything.
It's not entirely true. There's also issues and there's concerns from DFS with realignment and with MHSA. So those are kind of the other 2 big sources we have outside of allocations.
Mhm.
That is, for the most part, true for Medi-Cal, CalFresh, CalWORKS, those eligibility programs, we get a big state allocation. The problem though is that, especially with the mental health services that we have here, those funding sources are also not in great shape. So general fund struggling, realignment is projecting multi-year, multi-million-dollar deficits, and MHSA is just very messy because of Prop 1. So while we're allowed to hire, we actually have, 6 clinicians we just got permission. We're moving forward on a lot of these positions, but it's not as simple as, for example, a Medi-Cal or CalFresh public assistant specialist should be or would be, right? So that is the bad news here, unfortunately, but we've been given permission to continue to move clinicians forward. So that is the good news, is most folks in the clinical space, the child welfare space, some of our EPI and kind of public health folks will be able to move forward, but it's not as clear a path as it should be because those funding sources are also strained.
So when you say 102 vacancies, just roughly out of how many?
746.
Wow.
Can you predict about how long you think the shakedown for Prop 1 is going to take before we really know how much money we really have to spend on other programming? Because it just seems to me that there's no report from the state. I don't know if the counties know yet.
So I don't know if I can directly answer that question, but I can comment that last week we were at a forum by Carlene's new employer, right, and the California Behavioral Directors Association. And essentially, the message that advocates of mental health plans are giving to mental health plans is you can't afford to serve people that aren't your clients anymore, right? And so mental health plans have always put clients at the forefront, right? And the analogy I've been using lately to describe this is if you use a medical model and someone has a large gash on their arm, and they come in and you go, oh my God, you need stitches, right? This does not look good. But this is the ICU, right? So you need to go across the street to the urgent care. That's where they'll take care of you, right? They'll give you your stitches and make sure to clean the wound. You don't need the ICU, right? And so what has happened over time is that the mental health plans know, right, that the urgent care clinic or whatever, they don't see their clients, right? Sometimes, right? They don't see their patients. They wait for weeks or months, right? And that wound gets infected and it gets worse until you need it. And so the message we've received from the community over the years is, why does someone have to wait to be so sick that's when they can finally get your services? And the reason is because that's what we're supposed to be doing. There's these other managed care plans that are supposed to be doing the work of serving individuals who have mild to moderate symptoms, right? And so the managed care plans have sort of taken on the responsibility of some of the other managed care plans over time essentially to the detriment of the people that we're actually really tasked with serving. And part of the challenge is that the way that Medi-Cal managed care plans are funded in California is they have a capitated rate. So they get their money regardless of how much service they're providing. But we provide services at a fee for service rate, right? And the kind of the projection going down the road is at some point we're gonna get a capitated rate, right? But the state, using whatever magic they use to figure out what the rate's gonna be, it's going to look at what our billing is, right? And so the message to us as mental health plans is like, you need to get your house in order, right? And you really need to focus on serving the clients that you're actually responsible for serving, because a lot of these funding sources are drying up, like the Behavioral Health Service Act, for example, right? So I again, who knows, right? I think is the answer. I mean, my guess would be it's going to be a couple of years before anybody really understands what it's going to look like, right? But in the meantime, sort of these messages around hiring freezes, contracting budgets, all of these things where there are these drastic kind of financial implications. It's not just Yolo County, right? It's all 58 all 58 of the counties.
Yeah.
There's similar conversations happening all across the state right now, right? And so we're trying to prepare for that. We're trying to prepare for those kinds of situations. And so when we talk about the potential decisions that have to be made about reducing services, I think Nolan kind of alluded to this last month and the month before, right? Like, we have to operate a clinic, but do we have to operate two, right? Or three, right? And we may have to make some very difficult decisions down the road depending on what our funding actually looks like. The county operates at a structural deficit with general fund, but so does mental health.
Right.
Mental health has a structural deficit every single year. So like between $4 to $6 million for one reason or another, we are spending $4 or $6 million a year more for mental health services than we're bringing in, right? And so we have to get that. We desperately need to get a lot of that sorted out, right? So.
And it is a long-term structural problem.
It is a long-term structural problem, right? And so, I mean, it's terrible timing to be sorting things out, but it's also, in some ways, it's where we're at right now as a state, right? And where we're at as a county. So I just to your point, right? It's not just Behavioral Services Act, right? But that's gonna magnify some of these problems, because that's been sort of a source of funding to kind of tap into.
Yes.
Over the valve,
Right,
yeah, that's
exactly.
gone now, yeah.
So we've talked about over the course of time, the importance of building sort of that directory to kind of get people to the right place for services.
Right.
And as you talk about like focusing on your core services, like that becomes even more important,
Right.
Is redirecting. Is there, because this conversation's happening everywhere,
Right.
has anyone actually done something like that where they're mapping resources that we could use as a template to do something like that here?
I don't know if it's as simple as mapping resources, right? So my experience, I used to work in Sutter County, right? And so it's a bi-county mental health system there. Sutter and Yuba have a shared mental health system. And what we've experienced there is we would have clients, it's like, really, you should be going to the managed care plans. And then sometimes navigating that can be so complex, right? That it's difficult. And there we had a person who was hired literally that spent their entire day helping clients navigate the managed care plan, right? Right, helping them get connected to the resource, driving them there, right? Like getting them actually connected to the resource, right? Because it was just challenging and time consuming, right? So there is that model, at the seminar or the conference, that we were at last week. That kind of model was being suggested to counties, right? And you probably need to do a better job of helping your clients get across the street to the urgent care clinic, right? But just telling them where it is sometimes isn't enough, right? I think that sometimes, even for individuals with mild to moderate symptoms, it sometimes takes a lot of energy and to get up and make the decision to go and get help. And then to be told, no, you can't get help here, that can be discouraging, right? And so, I don't think it's as simple as just mapping out resources. I mean, I really think that we may have to invest some effort in a model similar to that. But I also feel like we have to do some advocacy as a mental health plan with the managed care plans that we work with to say, hey, if we're gonna have to do this, then you need to help fund this, right? Like if we're gonna have to help people get to you, you're gonna have to help with some of the funding, right? And we're seeing that in other areas too, we're seeing it with like residential settings where the rate that they get from managed care plans isn't adequate, and then the county is paying like a patch. So we're saying to the provider who's telling us, I can't serve your client unless you give me extra money on top of what the managed care plan gives us, right? And so it's not just providing like a map of resources. It's not just providing assistance with helping individuals get to resources, but we also have to hold managed care plans accountable, right? And I think that that's easier said than done.
Well, and that's just Medi-Cal. So that's only half the battle too, right? So we have to, or we've chosen to serve anybody. So for example, if you call CIP tonight and when that crisis clinician shows up, they're not gonna ask you for your Medi-Cal card or your insurance card. They're just gonna serve you and move on. If you have Medi-Cal and we can check all the boxes and cross all the T's and dot all the I's and get paid. If you have Kaiser, we get nothing, right? And the ambulance provider can bill like $50 or something like that if you have Kaiser, but there's part of the problem too is that we have made a choice to serve the public, right? Not just Medi-Cal recipients. So if we open crisis now in the receiving centers and to get in, you've got to swipe your Medi-Cal card that excludes everybody else, that's a huge problem. And so a lot of the private health insurers are really, they're really exploiting kind of a loophole here, and they're not stepping up and they're not providing services. 35% of the folks calling our after hours mobile crisis have private health insurance, and they're not paying, right? And the K through 12 mental health partnership, right? Was it 40% of the students that are using the services have some form of private health insurance?
I can't cycle, but I mean, I think it's pretty,
somewhere in that.
I think it's probably the low end of the estimate, to be perfectly honest with you. With the K through 12 school partnership, what many of the districts have chosen to do is really prioritize youth with private insurance, because they know those are the youth that can't get services, right? And so it makes it a subsidy for private insurers, right? It makes it difficult for us to sustain the project long term.
So kind of question for that. So yeah, access is an issue across the board, right? And I was just gonna say, even many licensed social workers, MFTs have stopped taking insurance. They're taking cash patients only because, COVID and inflation and everything. And so I know when I first came on the board, there was a lot of turnover. Carlene talked about it was really tough to get clinicians. I'm curious if that, when you were talking about vacancies, are you still seeing the churn?
Yes.
Or is that stabilized?
Yes. I mean, it's a statewide problem. Again, that was like a year or two ago, I can't remember, but San Diego County did a study and they predicted that in this last fiscal year, fiscal year 24-25, that they would need 20,000 mental health professionals, right? Like 20,000, right? You know what I mean? Obviously, we're not working at that scale, but I mean, it just, you think you're trying to compete with San Diego, for clinicians, right? So, I mean, it's still very difficult right now.
So are there other things that Yolo County can do? Because I know you can only raise so much, and then at some point, everybody just keeps raising.
Sure.
So I don't know, does Yolo County do an experience of work survey, or is there something that people are saying that, hey, these are, not related to pay, but other items that if these were improved, we might, or if these are things that the county could consider improving? I don't know, that's kind of a global question.
That's a great question. I mean, we've really focused, especially in this department, on culture and a variety of other things that really address work-life balance. There's always kind of a tug of war, sadly, I think, between our agency and the ability to telecommute. We have 66% of our staff have the ability to telecommute on some scale. So whether that's one day or full-time, and frankly, if you're doing telehealth all day on a laptop as a clinician, I don't care if you're in the office or if you're at home, but there is a philosophy in some places where folks need to be in the office. So a lot of places are pulling some of those capabilities now. So we're looking at ways to really push back and say, hey, this is actually keeping people here, right? Okay. We have a variety of other resources we've been focusing on around the DEI space, around cultural competency, around just creating an accommodating and flexible and caring workplace that we do try to work with. Our board is great in the sense that they moved to 100% of comp last year, which means that we, instead of comparing our employee salaries to 95% of comp, which was the standard for decades, we actually look at 100% of comp now, so it did bump salaries a little bit. But the problem, like you mentioned, is we raise ours and everyone else raises theirs, and then before you know it,
You're behind the eight ball.
Right. So, the county's added extra holidays and done a few things, but, really it's hard. It's hard to be competitive. And frankly, when Kaiser opens their hiring roles, and I'm not knocking Kaiser, it depletes the entire region, right? It's just.
But that's across the board in every healthcare
Totally,
specialty.
totally,
Right?
yeah.
I mean,
Yeah.
nobody can keep up with them.
Yeah. So, part of Prop 1, right, is the statewide workforce issues. They're taking some money right off the top to work on statewide workforce. I have no idea what that means or if that would be effective. But I mean, we need a pipeline of staff to really join this issue because it's a growing problem. And so you've got funding resource issues,
They
you've got
already had the
workforce.
WIC money.
Well, thank you for looking
Yeah.
at other things other than comp. I think
We try.
That's great that you do that.
And I think that while we still have some churn and turnover, our vacancy rate overall is much lower. And I think we've made some really intentional strides in the child welfare space. I think the mental health space is probably the next, but we unfortunately are often always hiring clinicians.
Okay, thank you.
All right, H.
Maybe before I get to H, I just want to make a note that this is not the message I wanted to deliver at my first meeting. I would much rather come in here and say, we've got all these great ideas for these expansive projects that we want to start up, and we're a progressive, forward-thinking county that is going to do whatever it takes to make all your wildest dreams come true.
I think it's kind of true. We just,
I mean,
within reason.
But so I just want you to know that, right? This is the reality of the situation we're in. So, speaking of which, Proposition 36, which is a ballot proposition that was passed by popular vote back in 2024, a few months ago, remember, before we were here. The long and short of the Proposition 36 as it has potential impact to behavioral health is that certain drug-based misdemeanors can be charged as a treatment mandated felony, right? And so my understanding of the statute that is relevant to this, which is Health and Safety Code Section 11395, is that if a defendant requests and a judge orders, the individual can be assessed for substance use and mental health concerns, among other concerns, and a treatment plan would be recommended, and the court could order it. And if the individual completed the treatment, then the felony would go away, and if the individual didn't complete the treatment, then the felony would stick, right? So what is notable about this is Proposition 36 was championed by our local district attorney, Jeff Reisig, and we've been working over the last few weeks with the district attorney's office and the probation department to kind of iron out what the local implementation of the requirements of Prop 36 are. And I think we're getting closer and closer to figuring out what this is probably going to look like locally. As recently as 5:30 p.m. today, I took a phone call where it sounded like we have something that is going to work, and I'm reluctant to say right now because I don't want to commit to it. But for whatever it's worth, there is no funding that is specifically identified to support this. So there's an assumption that we can utilize existing processes for Medi-Cal beneficiaries. Okay, so any Medi-Cal beneficiary that has a problem with substance use can request an assessment, right? And could be access to treatment if it's appropriate, right? So assuming that a defendant is a Medi-Cal beneficiary, there should be some sort of mechanism for us to provide them with services using some sort of existing system of care. There's some other nuanced questions around Prop 36 that are coming up in terms of funding that I don't really want to get into right now unless you absolutely insist on it. But for whatever it's worth, we agreed to work with the district attorney's office with regards to 3 individuals who already requested who requested an assessment, just to get a better idea about how this might work.
Is that like a pilot or you're just?
It's not really a pilot, it's more that the process hasn't really been completely ironed out yet, but we had these 3 individuals who are requesting services. And so the idea was for us to at least start the process, get a better idea about how that might work with our system, and really for us to get a better idea about the potential impacts in terms of, is this really are we really not gonna be able to fund this, or can we fund it, how would it work? So the idea was really just they had the 3 people who were ready, and so we said, okay, let's start with them and then we'll go from there.
Yeah, I think there's been 19 cases charged, but as you mentioned, the individuals have to agree to want to enter the program. So there's 3 that want to, and so you're assessing all 3, which is great. So
Yeah.
I know it's hard.
I think there's still some questions with the court that we're working through as well. What was the acronym that I always butcher? BSE or?
BSCC.
No, it was, I probably shouldn't say, there's.
BS.
We're working through some items with the court still too. There's something that the judges have to work.
DEJ.
Yes, DEJ. There's
Yeah.
something with the DEJ that we still have to work at as well. So that's, and I don't remember exactly what it was, but I probably shouldn't have said it. You're probably an expert. in this
We
space,
talked
so-
about this last night. My assumption here is that essentially this is a deferred entry of judgment, right?
Yes.
So that you're agreeing to a treatment plan, and you're sort of, everything's on hold until you get the
Exactly.
treatment plan. And so informally, I've heard that maybe some of the local bench might not be 100% on board with this either, right? So I don't know if that's true or not, right? But that would be sort of where a DEJ argument could potentially come in, right? Is the court also has to order this.
Well, it's the law.
I know
They don't have
it is.
much of a
I know
choice.
what it is. And again, I'm not trying to speak out of turn, and I'm not trying to spread rumors either, right?
So anyways, we're working through it. We think we have the treatment pathway figured out. There's a team working with the courts to figure out next steps there, and kind of if everything's working or not working, we don't really know. And then theoretically, we'll start moving. So.
Yeah, I think some background on this, because we're now the behavioral health, and we do have the substance use disorder area, is I believe it was in 2000 that our office partnered with HHSA to treat drug possession charges as a health issue. So instead of charging the crime, we referred them to get engaged in treatment. And the numbers were dismal as far as the engagement level. And so we did our Prop 47 grant. It was to address that problem. We got the grant, we're trying to make it work. And then I mentioned that Jeff Rice had championed Prop 36, and the addiction issue is personal to him. He has a nephew that's died from a fentanyl overdose, and another nephew that's homeless, is a opioid addict in Sacramento County. And so he's trying to deal with the addiction issue as it impacts the criminal justice system, intersects, it's personal to him. So he's probably getting a driven guy trying to make this work and pushing. So that's kind of some of the background on how we got to this proposition.
So wait, if 19 people were charged at the higher level to try to get them to take the services, all of these people, even though we're in this intermediate period, they all have gotten the services? Some of the other.
Well, they need to be, so, and by the way, to be charged with a felony, you have to have 2 prior convictions. And I've been doing a lot of work on this in my job statewide with different offices, so I'm pretty familiar with what's going on statewide level. Across the state, everyone's having challenges like like we're having in yellow. It's not, it's challenging, but, so for them to be eligible, they're eligible immediately if they're charged, but they have to agree to be assessed. And that has to be a conversation that they have with their attorney, and then they have to say, yes, I'd like to be assessed. 16, as of at least a few days ago, there might have been more charged since, have not, at this point, been interested in the program. That doesn't mean it won't happen. It could easily happen down the road. But only 3 so far have said, yes, I want to be assessed, and then see, what that looks like after that.
So, I mean, I give you good credit, I mean, maybe you have to because it's allowed, but to say, we're gonna try these 3 and see how it goes, instead of saying, we're gonna make sure this process is perfect before we try the 3, I like the fact that you're saying, let's just try the 3 and see.
Yeah,
We can get more
yeah,
information, we can do more,
Yeah.
it feels like it's being a little bit more proactive than waiting for something that you really understand how it's gonna work.
Jonathan said it very elegantly. It's just the level of detail that is required to make that simple 3-sentence statement work is 17 pages long, right? And so
Yeah.
every county is a little different. And I think, like you said, everyone's kind of figuring it out with a different flow. We're coming up with some solutions. The problem with this also is there's no additional funding attached, right? And so again, it's like what staff does this and how do you do that?
Another non-funded.
So but I think, we've got a good plan, and 3 is a reasonable number, and we'll kind of see how it goes. And unfortunately, it is the same pool of resources that all of our other Medi-Cal recipients use, but I think we'll get there. So.
Can you report back how it goes?
Yeah, I think.
I'm happy to put it back on the agenda for next month. Right?
We'll probably have at least like the bones of a process mapped out, I would suspect, in the next week or 2. I think probation's heavily involved. It's not just Health and Human Services. Probation's involved in the courts, the DA's office, public defender. So it's also one of those ones where it's like you need everyone kind of working in sync, which is challenging.
I think part of the challenge is it's not an unfunded mandate, right?
No, it's not.
It's not a mandate, right? So there's legislation that's in place, right? But it doesn't identify who's responsible for what, right? So it doesn't say behavioral health, you have to do this thing, right? So I think that is, there's no funding, right? And so, in terms of the last conversation I didn't want to have, right, with you, that's relevant, and so that's part of what's driving some of the conversation, and again, the other thing I don't want to do my second week into the new gig is get on the bad side of some elected official either, right? And we are here to provide substance use and mental health services to people who are entitled to receive them, right? And so I definitely want to find a way to yes, right? That's not the issue, right? The issue is really around how do we ensure that again, we're serving the clients that we're required to serve, right? And how do we ensure that we are being responsible fiscally? And so the decision, like, okay, these 3 are ready, like, let's start with them, right? These are 3 individuals that want mental health services, like we're putting the client first, right?
Great.
Yeah.
Question, we have drug Medi-Cal Yolo County for a couple of years now.
Yeah.
People who get treatment through the drug Medi-Cal, is that 100% covered by Medi-Cal, or is there a county portion of that that's covered?
It's a match as well, so it's 50%, and then we get a 50% match, so it kind of runs into the same, other issues that we've been discussing.
I just kind of, it seems like expanding the addiction services and treatment services is important because there's limited residential, there's limited providers in the county. So that was my question, was how much is Medi-Cal funded for that treatment for the people that are eligible for it in the county? It's like 50-50.
Yeah, so it's like for the permanent probation, AB 109, clients that go into treatment, they have that CCP treatment match to the Medi-Cal, which is very helpful. So the more that increases, the more people we can serve.
So if Prop 36 expands the number of people who need drug Medi-Cal treatment, that's going to have a 50% increased cost for county resources too. So it's not completely.
I wouldn't say that it expands. I think that these are individuals that would be eligible for treatment anyways. Even if they didn't get arrested, they could come and say, I want treatment, right? If they're Medi-Cal beneficiaries, right?
I just think that a lot of people don't want to get engaged in treatment until they getting the.
No, it'll definitely, it'll drive
You're
more volume.
Yeah,
gonna increase your
It's-
volume.
It's gonna drive costs up for sure.
Right.
So there's gonna
Which, you know,
be an additional treatment cost to the county
Right.
on top of what you're gonna
Right.
bring in from Medi-Cal. I'm just trying to get an understanding for how that math works.
Yeah, I mean, and, you know, I will be transparent. I was having a conversation with Carlene the other day, and I was wondering to what degree it might be helpful in this setting to maybe have a conversation or a presentation around like kind of how Medi-Cal funding works, right? You know, because I think that helps to inform the conversation, right? Because a lot of people are asking similar questions that you're asking, saying like, help me understand how this works, or why is that a problem, right? And so I'd be happy to have someone with a better understanding of it than me, help me put it together, right? But, I would love to do that.
I think that would be helpful.
Yeah, I think, yeah, because there's, anyways, again, it starts to get a little bit nuanced, right? But it's, in terms of the match, those are federal dollars. So any non-federal dollar we can use as a match, right? And again, I don't want to get into the whole presentation right now, but.
Okay, but we have a match issue for that.
Just how to match the dollar is really what becomes the ultimate funding question in every program, right? You know, because we get realignment dollars. Those are dollars that we can use for match, but we only get so much realignment funding. So then when we run out of realignment dollars, you know, you start looking at MHSA, right? You start looking at grants, and you start looking at alternate funding like CCP or whatever, right? You know, and it's like, once you run out of dollars to match with that, then you're kind of stuck, right?
Okay.
Then we have to ask for general fund.
I wasn't tracking that issue
Yeah.
before completely.
And I think next year, for example, so I just went through the 25-26 budget requests for the entire department. Every single contract that had increased realignment surrounding mental health was deferred to adopt it. So I'm not approving any contract increases because we don't have money, we're in a deficit. So we're gonna have to rob Peter to pay Paul in a lot of instances. And so again, as we're increasing these costs on match for Medi-Cal, I'm already holding all of the existing contracts we have that have increased requests because I don't have the funds next year to pay for them, so.
And that same match applies to the peer support with the certified peer support workers.
Yeah, I mean, well, wherever we can find the match, but yeah,
You have a match there too?
It's any service that we provide,
Okay.
right? Any service that we're billing Medi-Cal.
I like that just kind of went on.
Right.
No, it's all
Yeah.
drinking from the
Yeah.
same well, right? That's
Yeah.
the problem, is all these things have their straws in the same cup, and it's, you know, it's hard for us to keep filling that cup up to pull down the match. And then, I don't want to get too far down the rabbit hole, but we have a whole other issue with billing, right? So we bill about $24-25 million in Medi-Cal revenue a year. We really struggle with that, and we have turnover, and we have teams and technology issues, and we have audits and all sorts of different things. So we're dealing with a small fire right now that, you know, I don't know if you guys have used our electronic health record in any of your respective workplaces or jobs, but there's a lot of issues with Avatar, right? And so not only can we bill stuff, it's can we actually bill and get that revenue into our fiscal side of the house is the challenge as well. So it's a struggle.
Any more questions on 36? All right, we're a little bit behind schedule.
As requested, we are going to talk a little bit about transformational change partnership, and I'm going to be 100% honest with you. I'm not intimately familiar with this particular topic, but we do have Julie Freitas, who has offered to be here today to maybe field any specific questions regarding this. But essentially, the transformational change partnership is a group effort from, there's multiple parties that are involved. So the Steinberg Institute, Third Sector, the University of Pacific McGeorge School of Law, LCCI DHS on here, Stanford School of Medicine. And the idea here is to provide county health and human services teams and their partners with knowledge, learning experience, and implementation support to achieve transformative system change. So my understanding of our current iteration of this is that we were approached, again, as you all may know, our former director works for the Steinberg Institute, right? So there's like this kind of connection to Yolo County right off the bat, and they wanted to pilot this approach. And so they approached Yolo County, they told us it would be free for us, which is great because it sounds like they might be charging other people. And it's really been centered around behavioral health and kind of working with individuals in the local behavioral health system to develop like leadership relationships, whatever is necessary to do some transformational change within the county, right? And so I can let Julie talk a little bit more about that if you want some specifics on it. But essentially, this has been a cohort that was set to go through these 3 specific phases. So assessing, implementing, and continuously improving and replicating success over the course of 9 months. And it's actually just about to wrap up. So there's only a couple more weeks left in this, and then this kind of it's done its job here, right? So there's another transformational change partnership project that I believe is out there locally that's being led by the Yolo County Office of Education, but I'm not informed enough about that to speak to exactly what's going on there. But I know Garth Lewis has talked about this. Yolo County Superintendent of Schools, Garth Lewis, has spoken about a desire to get that moving, and I believe that is something that's happening. I'm just not as well informed about it as I'd like to be.
All right, thank you, Tony. Appreciate that report, robust report. It was great. And is there any public comment? I see we have some members of the public here virtually. Any public comment? Okay, we'll move on to the Board of Supervisors report. And we have Supervisor Frericks here with us. Supervisor?
Well, good evening, everyone. It's good to see you all, although virtually this evening. Happy New Year. I know I've seen some of you in person, and I know it's February, but if I haven't seen you in person yet in the year, it's always never too late to sort of say Happy New Year. So really appreciate your service. First of all, I just wanted a couple of quick items. Nolan did a great job, covering some of the budget stuff. Happy to talk more about that, of course, too, but he definitely sort of let everyone know sort of the real I would say, severity of the situation around our budget. A few items though. So we had Supervisor Provenza, of course, finished up his service at the end of the year. And so Supervisor Sheila Allen was sworn in on January 6th. So joining our board this year, very excited about that. Mary Vixie Sandy is serving as our board chair this year, and Supervisor Allen is the vice chair. We rearranged some of the liaison roles and boards that we all serve on. So Supervisor Vegas is continuing as a co-liaison for the local behavioral health board, but I was also named as one of the co-liaisons. So that's why you're seeing me this evening. Really excited about that. This is so appreciate the work you do on a regular basis, and just this is an issue that means a lot to me. So I'm not sure I'll be at every single meeting, but I will try my best to be at most of them, and also occasionally in person, of course, too, not just on Zoom. But I really appreciate being able to listen in on everything this evening. A few other quick items. I would say one, obviously, yes, uncertainty as it relates to the sort of new federal administration. It's just a real challenge. But I think it's important to just keep in mind a few things, as much as I think we're all probably a little bit worried and stressed about that sort of uncertainty in that situation. We have a really, I think, great set of values here in this county. Also here in California. California has always been a place that is all about protecting people. And especially vulnerable populations. I think that's exactly what Yolo County does too, and that's what the role of counties by and large. And so we're going to be continuing to do that, even in light of just sort of uncertainty as it relates to the sort of federal situation. A few other items. Just really want to appreciate Carlene Jakowski and all of her great service to this county, and wish her, of course, well in her new role. She's obviously pretty close by still, and I think it's still lots of opportunities for collaboration with Carlene and in her new role. I'm grateful that Tony is in this interim role as mental health director, and just like Carlene before, wearing multiple hats. So thank him for his service there. one quick item just on the budget discussion and that you all had, and Nolan provided some sort of additional details there, but around the vacancies especially, I think it's just a couple key points. One, some of these vacancies have been around for a minimum of 3 years and some some cases longer than 5 years. So it's just, I mean, and with an inability to fill some of those vacancies. So, but not for lack of trying, of course. I think the board is just very serious about trying to figure out the structural deficit, and there's a lot of ways to do that. There are many sort of tools in the toolkit, including increased revenue and sort of looking at conversations with the other jurisdictions in the county about property tax share. And there's just a lot of discussion going on there. So we'll see how that sort of plays out in the months and year or years ahead. And then also, just as it relates to some of these vacancies and the issues, it's not just a challenge that's in the health and human services area or mental health area. It spans many types of jobs. I mean, and and it's not just Yolo County either. So I really appreciated your discussion and the talk about increased wages and things of that nature, and kind of that the private sector and public sector, and kind of how it goes back and forth and such. I just we're seeing a good example is like the correctional officers positions in the Yolo County Sheriff's Department in the jail. We have about 28 vacant positions there, and some of them have been on the books for 5 years at this point. They just have a real challenge to hire people into that role, for example. So again, it's happening in other sectors too, and other areas of the county world, and then of course across the state. So I'll stop there for a moment, see if there's any questions, certainly, but just I appreciate the opportunity to spend a little time with you this evening.
Thank you very much. Are there any questions for Supervisor Ferris? No? Okay, thank you. And we'll move on to criminal justice update.
Well, now that I'm not in the DA's office anymore, it's hard to get information. But I will say I did go to a mental health court graduation Monday of this week. We did have a graduate. I also learned that there's currently, the DA's put a hold on new people going into mental health court AIC while this Prop 36 issue is being resolved. I don't know if that's changed since Monday or not. So that's frustrating, I guess, because I want to get people in these programs. I would note that there is, it's kind of outside of criminal justice, but there is an opioid coalition meeting on February 28th at noon. And I encourage people to try and, if they can find time to make that meeting. I'm not sure if it's on Zoom or not.
It is, it's hybrid.
It's a hybrid, thank you. But it falls under our umbrella now. It's Behavioral Health Board to understand the addiction issues in the county and treatment. And opioids is a big one, and the fentanyl deaths have been going up over the years. And so getting a feel for how that works is important for our board members here. I will note that I was going to give an update on what happened last month, but it was canceled at the last minute. So hopefully we'll have one this month. That's pretty much all I have right now.
Is that link going to be sent out for that meeting?
What you can do is if you, can you send out Glenn Johnson's email? Because he's the point of contact. And if you want to get updates on the Opioid Coalition, send him an email. Let him know who you are, and he'll put you on a distribution list. It's open to the public. And so it's not just county or city employees, but it's open to the public. And so it's a wide mix of individuals that show up. I believe we have representatives from some of the hospitals also. Julie can probably tell you more about who's shows up there. I try to make it, but I have made a call. I think it gives an idea of what's going on treatment-wise in the county.
Any questions for Chris? All right, ad hoc committee report.
So that's Nikki and I. So we received nominations and interest, and so we've talked to everybody. We did find out today that we are early in the process, very, very early in the process. This wasn't supposed to occur until March because apparently the new officer slate doesn't go into effect until June or July.
To July 1st, the beginning of the old fiscal year.
So-
You're stuck as chair.
Good try, John.
I think he knew that.
So we'll probably come back to this board with a slate recommendation as we get further along. But we've done a lot of the work already.
Yes,
The vote will be in May, according to the bylaws.
yes,
Yeah.
the vote will be in May. We did
So
not
more to
get
come,
started
things
yet.
to look forward to. Just keep coming back.
Maybe if we had a board with 50 or 60 members, we should have started this early, but.
Better early than late.
Sure.
And heaven knows we've been late often enough.
Yes, we're not this time.
The long-range planning calendar, I know, did we get that?
For our Melanie's site visits, we were talking about site
Do
visits.
you want to talk some more?
Yeah, we do. We're ready to go out to another site. First of all, where would you like us to go? What would you guys like us to provide feedback on?
I just added it.
I missed the first one.
Okay.
She said
And so-
farmhouse. No, they went to
We went to
Safe Harbor.
Safe
Oh,
Harbor.
Safe Harbor.
Okay.
Yeah.
Okay.
So we had discussion before about going to various places, like, I don't know, the wellness center. Somebody talked about a hospital, having access to go into a hospital. Wasn't that you that mentioned?
I think I mentioned 3B North, that's something
Yeah.
that the mental health court team was able to go in and get a tour of the facility, so you have a better understanding of what it was. I think that could be helpful for people to see, exactly, when we talk 3B North, what is it? It's a lax psychiatric facility in Woodland Hospital, and what it looks like, what the conditions are in there for the individuals.
I definitely have interest in that, but what about everybody here? What do you think, what is a value to you for us to go out and,
I think one of the discussions previously was to identify the locations, and then Carlene had mentioned there might need to be some contact from the county to confirm we could go in, because there's release things and other things to actually go into these facilities.
Do you guys want to go to 3B North? Because I can contact someone over there. If that's what people are interested in.
and make it, we're gonna join us this round?
Yeah, I have no interest to go to 3B North. You guys can go. I'll
Okay.
go to the next time. Yeah, thanks.
Yeah, I've been there, so.
Okay.
Yeah, I've been there.
I have two.
Well, that's the thing that I know there's some of us that are new here. And so for us, it's all new, but
No.
to some of you guys, you already know what's going on with some of these places, so.
It doesn't have to do with the local mental health board, it has to do with my crazy life.
I was just trying to give someone, because I've been there, if there's someone who hasn't been there, they have the opportunity to go.
But it's not in Yolo County, but we send people there. Would be a great place for us to look at, would be Heritage Oaks.
So I think we can make that happen. So we recently, just within the last 2 weeks, met with their COO and some of their leadership people.
They being the
I'm sorry, from Heritage Oaks and Sierra Vista, right? And so essentially, in part of that conversation, they were like, we'd like you to come tour the facilities, right? So Heritage Oaks, Sierra Vista, there's also some other facilities that they have agreed for us to potentially visit. So for example, there's a couple of different sites in Yolo County that provide some adult intensive day treatment services, right? And anyhow, I'd be happy to share that information when we get that set up. If you would like to participate in going to some of those facilities. We're trying to set aside one whole day and do like a lot of driving, to be honest with you, because we're potentially gonna be looking at 4, 5, 6 sites.
You mean you guys are planning on visiting?
We were planning on having our behavioral health leadership team go and visit some of these sites. It all came together very, very quickly within the last week or two.
What about the Placer County, their crisis that they,
They're-
yeah, I mean, that might be interesting to us, because that's similar to what our crisis would look like.
Yeah, we've done there has been a team, Jonathan was able to go at one point in time. We've done a tour there. It's great. We could arrange for another too.
I don't know, that might be helpful too, yeah, I don't know.
There's a facility in Sac too that we are kind of keen on.
So again, just because someone brought up Heritage Oaks, right, and it just coincidentally, we are literally planning on putting together some kind of a tour that includes Heritage Oaks. So I can forward the information. I saw that Jonathan sent out an email today, and does that email address just go out to everybody on the local mental
I
health
said,
board?
no, so that was,
That goes to me directly.
yeah, that
Oh,
was,
okay.
I thought it was, that didn't go to anyone.
Either
Except for
way,
Christina.
either way,
Appreciate it.
either way, well, I will, once I have everything firmed up, I'll give you the information, Jonathan, and you can communicate it out.
The tentative date is March 14th.
And the reason I'm mentioning that is because these are, I mean, Privy North is good at what it does, but what it does is limited to 3 days.
Hypothetically.
But some of the other places I'm talking about are places where people go for longer periods of time. It's kind of institutional disease places. I think that would be very interesting, because then the real question when they come back to Yolo County or are ready for the step-down placement, finding an appropriate step-down placement has been an issue. So that's why I think that's a really, I mean, it's an issue from Privy North too, but everybody knows that Privy North is only gonna be 3 days, so.
Clarifying question though, what is the, because I guess I'm a little confused, because you guys were doing site visits and you came back and you gave a report out and it was awesome, and we saw kind of where there were gaps. Is that like a mandate on our charter that we would then go out and like look at services? Like, because then to your point, Nikki, that would then connect the dots to say, we really should be looking at these types of programs.
Yeah, I was thinking the same thing, but.
But I don't know.
Yeah, that's kind of a sure, I had the same process question is, I know we're governed per our WIC code to conduct the site visits, but I think in the spirit of what Christy had when she was initially championing this effort was to tie an action to act on whatever gaps or what have you are having.
Right, it's important to me, it's important because we need to have a good picture of what the continuum of care is.
Yeah, so
that's.
Because I kind of see two buckets. We're talking about, it's great for us to understand how mental health patients in the continuum are taken care of and what services, what that looks like. And then there's we are, evaluating services that are being provided, to your point, and seeing where the gaps are for those continuums.
I think we already had clarification that we're not really doing that. Yeah,
No.
we're just doing site visits and we're just interviewing and maybe gathering insight.
That's an
To share.
evaluation and assessment.
It's not like we're trying to get away from the terminology though, or like monitoring,
Yeah.
right?
No, but I think we're just trying to come back and say, are we meeting the consumer needs? And what questions do we have? And then there's a lot of great questions for Carlene and you guys to help us understand where the gaps were based on what you were hearing from the consumers that you were interviewing.
Yeah.
So evaluation assessment might be strong, but it feels like part of
And
our
I
charter.
wasn't there
is
at
to
the
do
first one. I'm new to this right now, so I don't know. How did it?
We did kind of ask like evaluation need questions
Yeah.
to both the consumer and the people like giving us the tour of the facility. But then, like, the thing is, like, by visiting, you kind of are inherently a little bit assessing,
Where we wouldn't be going in and evaluating 3D North, for instance.
No.
We would be going to see, to John, like, what services are there, and that's
Yeah.
just as important for us to understand that.
Right.
But they're two different, I see them as two different distinct actions.
There's a professional evaluation that
Correct.
you're gonna have with the contract, which I don't think is what we're looking at, but our duties and responsibilities do have review and evaluate Yolo County behavioral health needs, facilities, services, and a bunch of stuff there. So going out and seeing what these services are and having an understanding of them helps us with that evaluation. I would think that, I believe that the primary medical provider for addiction treatment is Communicare.
Communicare, Fourth and Hope, but yeah, Communicare mostly.
But as far as the outpatient, I guess,
Yeah.
Communicare. So it might be going visiting Fourth and Hope, see what that facility is, going to Communicare, getting a presentation of what their treatment programs are,
Yeah.
so we understand what the Yolo County residents who are medical eligible are getting. Might be a other site
I
visit.
think that'd be great. Yeah, I think Walter's house, the old location is being brought offline. They're bringing the new location online, so that'd be timely as well.
Oh, good.
Yeah,
So Nikki, does that meet your need as far as assessing step down services?
Yeah, I mean, I think, my whole thing is that there is a continuum of care. What we're hoping to do is to get a clear understanding of how those fit together and how the transitions operate and all of that. And that's really, I think that's really important. But, you know, I don't see us doing evaluation. I mean, I was a professional evaluator for a while, so not that, but getting a sense for what.
May I make a suggestion? So we contract with facilities that are casually called PUFs, psychiatric health facility. One of them's in Yuba County. We've contracted with them for years, and it's an alternative to inpatient psychiatric hospitalization. So 3B North, which is obviously located here, or the facilities in Sacramento. So that may be an option if folks do stay there longer than 3 days. And so we've had a good relationship with them for a number of years.
And so there are all of these other kinds of options out there, and it may sometimes depend more on where the opening is.
Absolutely.
But, you know, but getting a clear understanding of what happens when, fill in the blank.
So
So I
could
was gonna
we,
say-
Tony, could we, because, you know, I did go, as you said, Nolan, to Placer as a representative of the local mental health board. Could a couple of us join your leadership team and visit some of those psych facilities?
I think that'd be fine. We'd have to check with it, but I think they'd probably be open to it. So that would certainly be an option if you guys wanted. But then that'll be kind of a longer, fuller day for folks,
Yeah,
but it could be interesting.
Let's start with that.
So I think that would be in conjunction with this other work, or that would be in place of?
I think in conjunction.
Okay.
And we could plan a couple throughout, you know, the next 12 months here or there, but this one is coming up soon, and it'd be a good opportunity to see some
Yeah,
ideas.
I think we could probably get a couple members that would love to join you guys.
I mean,
Something I want to really emphasize in how like the hospital connects with the crisis continuum, I think it's absolutely essential that the board understands how conventional psych hospitals run, and it's important HHSA understands how psych hospitals run, because the thing is, like, I think kind of it's been said in the past, like, oh, well, they're a private agency, they're not the county, and like why are we like looking at this, right? But the thing is, the fact is, residents of YOLO are getting referred to these facilities and they're getting discharged from these facilities. So we have county residents kind of encountering that and kind of have to understand that system. And the thing is, that's where 5150s go. You know, you got 3B North in the county, like everyone else is going to Sierra Vista, Heritage Oaks, Center for Psychiatry in Sacramento, or somewhere in the Bay, you know? So like, I think it is really essential that like there's an understanding of what happens in psych hospital. And I'm glad you're already kind of like going to kind of like get more understanding to see what's, you know, what services are offered and kind of how they're run. And another thing to add, like the 3 days, it's not really 3 days, like, you know, 5150 is 3 days, like often it gets extended into like a 5250, which is up to 14. And, you know, anecdotally, like people can be there even longer. So I think the average stay is something like 5 to 7, really. Yeah, so just.
Because even in EDs, they're more than 24 hours.
Yeah, and if they have ICU beds or SCP beds, it's always longer than 3.
Hey, Christina, can you add this item to the agenda on going site visits as ad hoc?
But essentially it's important to kind of, like Nikki said, connect all the dots of like, okay, someone's in a mental health crisis, okay, mobile crisis, COPS, or co-responder, receiving center, hospital, like, or ER, like.
All the facets.
It would be
so
nice to
we
see the
kind of
behind
need
the
to be able
scenes,
to
yeah.
connect all the dots of this system and understand it at every level, because otherwise, like, if someone is having a bad experience in one part, it's gonna kind of ruin the whole thing, even if it was great up to that point.
Maybe we should add here.
Yeah.
Making point that continuum of care is important for the addiction side also, because you have a residential program with someone who's chronically homeless is successful at that, where do they go? Because there's a gap there. And having our team here have an understanding of that process is important too.
And I think initially that's what we had talked about, was trying to hit the different places and do multiple site visits, not just 1 or 2.
Yeah.
I think we plan on doing more. So that would be a good start.
And some of those locations have both mental health services and addiction services, or they're building that. So that might be part of the conversation when you're visiting.
some of those locations.
One more idea for a site visit, so then I think you mentioned like visiting like mental health services in Placer to kind of see what that's like. Marin has a crisis stabilization unit that is kind of basically like a model system.
Yeah.
So that would be a good place to go to kind of like get a sense of how a crisis stabilization unit, so different than a receiving center, 5150, they can take 5150s, right? So, and it's like a higher level of care, so it's more like a psychiatric ER versus psychiatric urgent care. So that'd be a good one to visit to kind of get a sense of how they operate.
I was just gonna add that I'd be happy to join the ad hoc committee, because I think something to actionize the work and to direct the chair to do is after each visit, develop an executive summary, because what we're saying is we don't have funding to increase or develop new programming or provide resources, but we can still demonstrate through other efforts how we're still meeting the demands of behavioral health work and support, and still be able to produce action-oriented work that can still be presented to the Board of Supervisors, because I think absent having that paper trail that demonstrates, in spite of funding, we've found other alternative ways to reach the messaging. Plus, it's not that we're doing nothing. Go back to the last 2 years worth of executive summaries where we've committed to our WIC requirement, continue to notate the deficiencies, but then also our efforts to find those gaps and within our wheelhouse, act on them.
And I just want to say that my perception over the last 15 years is that the number of people falling through the cracks has reduced. I mean, I really do believe the Mental Health Services Act has helped us to keep more people served for longer periods of time, so that they aren't just leaving a facility and then decompensating so that it all has to happen again. There's no way to get any adequate data on that. I mean, we just have to kind of get a feeling for it. I mean, I'm sure there is a way to get it, but it's short of something more involved than I was thinking of.
All right, did you have a chance to look at that card yet?
Yes, and I did it,
Can I
so
make
should it go down?
one comment on that, John?
I just didn't know where to.
I haven't signed it yet.
Oh, okay.
But I think I wanted to add on to Dee's comment. Dee, I really appreciate your comment. I think the next couple of years are not going to be pleasant. We're going to be cutting, reducing, shutting down.
Could you say that one more time, though?
Sorry.
I don't think anybody's ever said this year's gonna be awesome.
No, well, the next couple probably. Well, where I'm going with that though is it'd be great if you guys looked at our wellness centers. You took a trip down to the mental health, the health court. You took a trip down to see our clinics. You took a trip, maybe we have our clinicians do a show and tell out on the street with a white band. Because what I'm saying here is that as we have to make these hard decisions, the board is going to lean on you for if we have to reduce programs, where should we reduce, right? And so I think the more that you guys see any and all of our programs in action, whether it's the crisis system of care, it's these just hospital systems, psychiatric hospitals, the more that you guys get boots on the ground exposure to all of the services that we provide, when push comes to shove and we have to change, reduce, shrink, they're going to rely on your subject matter expertise and your guidance to some degree when they're making those decisions. So Tony and I can make our recommendations as long as we say it's because of this, that, or the other, but that's exactly what they're going to rely on you guys for. So I really like the kind of the assessment piece that you're kind of going at, but I would just encourage you to think kind of globally in terms of the mental health care system. MHSA touches every part of our mental health care system. And so unfortunately, as there's scarcity, they're going to look to you as subject matter experts on kind of where should we really reinforce, where maybe should we shrink, and I think that'll be invaluable. Simultaneously, if and when someday those budgets increase, they'll look to you to say, hey,
Where do you put the next dollar?
Right. So that's just kind of what I think would be helpful over the next year.
And I think that's great. I think that's what we've tried. I think the other piece that we talked a lot about last time was data. And I think this board is really curious about data, because we also need data. So we need to be able to get the feel and how is this going, but we also need the data part to say what's working.
Well, I think at least on the contract side, we're there, right? Or we're getting
For
there.
sure.
I think internal staffing wise, we have some preliminary data. That's very tough for us to pull as well, but we can share some of that too.
Just, I think, heads up, that's probably coming.
Sure.
Okay, and I just wanted to mention the form that you and Sarah used when you went out. that was earlier developed. It looks like we may have to take a look at that, right? So maybe we could send that back to Tony. I don't have a copy of it. Will you send that to Tony?
Which
And you
one?
take, it's the form that they used when they went on the first site visit.
And-
So,
It's a Google Doc, I can send it.
Okay.
so Carlene, you may want to talk about that. You guys met with Carlene and you.
My understanding from Carlene is that when you want to visit a facility for this purpose, then she would reach out to them in advance to kind of like, get that ready, right? And so, is this related to this form in some way?
Yeah.
Yeah, so it was a form that we took on our site visit and it had
Okay, all right.
pre-established questions, so we kind of went through the
Got it, okay,
questions.
yeah.
And I'm not sure if this is what you're touching on, but I think we did our first visit pre-Prop 1 taking effect and implementation, so we might just want to go back to the form to ensure that there's no language that needs to be updated to align with
Could be a whole.
Prop 1 requirements. So I don't know if was the spirit of your request, but I can gladly review and then
Okay.
we'll get it to you and then that'll initiate our next
Perfect.
visit.
Okay. You're like,
All
don't give
right.
me more work.
I'm gonna table 11 and go to public comments. Public comments, anyone?
I wanted to bring up, so I saw on the I'm reading from the page right now. So I saw on the Davis City Facebook page that they have a meeting on February 12th from 7 to 8:30 p.m. And it's about, it's run by the Police Accountability Commission and the Social Services Commission of the city. And then it's for social services in crisis. So then they're kind of giving like a community meeting about like who you call during crisis. And apparently there's going to be NAMI YOLO, Davis Community Meals and Housing, Davis PD dispatchers, and the Davis Streets team there. So that might be a good place to go for some overview. That is on February 12th.
We also might be there.
From 7 to 8:30 p.m.
They might also be there.
Is that an email?
Yeah, that is just posted on social media.
Is that their city council meeting?
No, that's it's an event at the Veterans Memorial Theater.
Okay, thank you. What date was that?
February 12th.
All right, public comment?
Christie.
Hi, thank you. Hi, everyone. Behavioral Board of Yolo County and Supervisor Ferrix and Julie and Tony. Thank you all for your service. Glad to see you all in action. I just want the couple points I wanted to make. I wanted to remind the board that the jail is an ideal place for a site visit, and we've discussed that in the past. The jail houses many people that are entering the county's behavioral health continuum of care. That's where all the AIC and MHC candidates are coming from. And at this point, that is a major access point to treatment because there's not a whole lot available at this point. So I wanted to remind you that they were building a new pod or a housing area in the jail last year, and they were supposed to make it ADA compliant for mental health patients. So I know that Julie has had some contact, hi Julie, with the care services coordinator there in the jail, and I want to encourage the board to not forget about all of the people that are waiting for treatment and services in our Yolo County Jail tonight, and remind you also that the county implores very large contracts with a mental health provider in the jail. So that's something that should be on the radar and not forgotten about. Also, I wanted to just point, I loved hearing Supervisor Ferrix mention that the county supervisors are considering other funding sources for, filling some of the gaps that are happening across the county, and just encourage the supervisors to maybe looking at a behavioral health fee that could be added to property taxes throughout the county. So I know that there's a shortfall. We understand that, but looking at new ways for revenue generation to help provide the important public safety services, I think that that's really important. So I just wanted to remind the board that the jail is something that's in our purview and that needs to be remembered. Thanks.
Thank you, Christy. Any other public comments? All right, we're ready to adjourn our next meeting.
Before we adjourn, Maria, did you want to talk about the ad hoc before we leave, or
Oh, I did. Which one?
It's what you sent me right before. It is consider an ad hoc committee to work with HHSA and potentially NAMI to build a tool which can be posted to the.
Yeah, so Tony talked about that a little bit when I brought it up earlier, where he said that it might be difficult, at least right now, just because it's not just posting a tool is what I got from you. That, you know, it's the routing and not sending people to a place to get another door.
So, I mean, I don't want to discourage it.
It's just,
You know,
it's
so like, but
complicated.
I think I was just trying to illustrate that it's not just about that, right?
Yeah.
But that doesn't mean that that's not helpful, right? It doesn't mean that there are many people who would appreciate a tool like that and it would serve them well, right? So, I mean, I definitely don't want to discourage, I just don't think only having a tool is enough, and that was really the message I was trying to make. So I apologize if I can't.
Oh, no, that's okay. I just,
If it was that cut and dry, it would be done already,
Right.
probably.
right,
So we can put that on the future agenda?
yeah.
So it would be, the concept would be to work with Health and Human Services to develop something, yeah.
You wanna add that?
Okay.
Next
It's kind of like a
And we
local
also
resource
talked
guide.
about,
Okay, yes, the resource guide.
Yeah.
And
then
the scope would be, let alone development, but just mapping out kind of the issue and then allowing us some time to think about how to address it.
We have another project that we might be able to like feedback off of as well, right? So, yeah.
Because we talked about this last meeting too, and I think it's also a resource. I mean, you know, like people know this NAMI, they have classes and for families. And there's so much out there that if we put it in one stop shopping, basically.
Right.
we talked about putting something about Medi-Cal on a future agenda too, to understand where all the, how all the funding sources work.
Like the presentation he was discussing earlier.
Right.
Yeah.
Can't wait.
All right, so March 5th is our next meeting. That's my mother's 94th birthday. I will be in Los
Wow.
Angeles.
You better not be here.
I'll be in Los Angeles, so.
That means what's the date on that?
March 5th.
Okay.
Are we zooming in, right?
That's exciting.
Yeah, we'll sing happy birthday.
No, I love it.
That's right. Oh, perfect. Good idea.
Everybody's a bit of it.
Assuming we'll